Darshika Shah from the Clinical Engagement Team at Dogplexus. Welcome to a brand new session of VAI, that is Venous Association of India Master Series. Thank you for showing so much love to our previous sessions. And if you have missed out any of them, you can always go back and watch them on Dogplexus archives. Also, a very special thanks to Dr. Bedi for his consistent efforts in setting up this informative series for our Dogplexus community. So VAI has been instrumental in promoting the knowledge about venous diseases, their pathophysiology, investigations, latest therapies, and research in venous disorders. So these sessions in collaboration with Dogplexus will be knowledge sharing sessions from expert lectures by members of the Venous Association of India. Our topic for today is Phleboarthrosis of the lower extremities due to chronic venous insufficiency, an underrated condition. So this chronic venous insufficiency is an underrated and underdiagnosed medical condition that is associated with osteoarthritis. Patients with Phleboarthrosis are more often misdiagnosed with knee, foot, or ankle arthrosis. So on today's VAI Master Series session, we have with us Dr. Malay Patel, who's a renowned vascular surgeon, endovascular specialist, and a phlebologist practicing in Ahmedabad. He's a former president of the Vascular Society of India and the founding president of the Venous Association of India as well. So welcome, Dr. Patel.
Thank you. Thank you. Thank you for that wonderful introduction. And I thank Dogplexus and especially the initiative taken by Dr. Bedi from our team, who is one of our leaders. I'm the current leaders who is leading us. Of course, we have other leaders, and good day to all and everyone who is online. And I am going to talk to you about a condition that we started conceptualizing in our Venous Association of India a few years ago, and then started to discuss this, that there is an association between chronic superficial venous insufficiency and arthritis or early arthrosis of the lower extremity, especially the knee joint. Because what brought it to our attention was that, say, like the number of knee joint replacements have suddenly, or not suddenly, in a very short time, have increased to such an extent that it is very difficult to explain that why all of a sudden are Indians having bad knees. And then we started wondering, and then you look at these people's legs when they come after knee joint replacements and they're still not settling down, and then the vascular surgeon or the phlebologist are referred this case by a dermatologist or somebody else who finds that there is darkening of the skin or there is problems with the mobility, and that's where they come to the attention of the phlebologist. And we started discovering that though the varicose veins are not visible, there is underlying severe superficial venous insufficiency. And so let me begin my talk with the title, with Phleboarthrosis of the lower extremities due to chronic venous insufficiency and underrated condition. I am the presenting and conceptualizing author. The data collecting author has been Roy Varghese from Ernakulam and in Kerala, and data analyzing author is Dr. Manjusha Rajarshi, who's a PhD in data analysis, and she's from Mumbai. Next, please. We have no conflict of interest and we have no source of funding. We have done this all out of interest or for the love of the science of this, please. Next slide, please. So what is Phleboarthrosis and what is the pathophysiology? I will explain it to you in this little busy slide over which I will take some more time. But chronic venous disease or insufficiency, as is being known as CVD or CVI, and I try to use the word CVI in many of these presentations because chronic venous disease could be chronic vascular disease. It presents as osteoarthritis or arthrosis, as you would like to call it, and it's a chronic lifestyle limiting underdiagnosed medical problem. Now, when you look at the venous reflux as the source of the pain in OA, and one of the primary cause of OA was reported more than 50 years ago. And we were surprised when we saw this, that it was reported 50 years ago, and then suddenly it was lost in the literature, in the English literature especially. And people started to brush it aside, or more people didn't talk about it. And CVI manifesting as OA is less known and not considered as part of the clinical examination and diagnosis. And that's where it all started. And I guess the reason was that most of these patients, or most of these sufferers, did not have visible varicose veins. At the most, they have telangiectasis or spider veins. And this all had again to be revived with the advent of the ultrasound, and especially the ultrasound machine entering into almost every small clinic of the world, and in India, every village. So the underlying diagnosis of CVI is most often missed in those presenting with OA. Patients are usually treated for knee and ankle arthrosis and focal foot bone avascular necrosis. So it's basically being referred to as a musculoskeletal issue, and the patients keep on going from one doctor to another. They maybe go to a dermatologist because they find that there's some eczematous skin lesion in the lower leg, or there's some hyperpigmentation developing in the lower leg, and the patient just keeps on moving. And I've had patients who then ultimately had both their knee joints replaced, or have been going to the dermatologist for the last 10 years. Therefore, evaluating the link between OA of the knee and CVI among the patients presenting to a venous clinic was considered in this prospective study in India. And later on, I will come to I think in the next few slides, you will come to know about the way in which this study was done. This is basically a correlational study, but the correlation is very strong and the outcomes are very positive. So we have started believing in this, what should I say? Not new terminology, but rediscovered terminology known as Phleboarthrosis. Next slide, please. So the purpose of the study was evaluating the link between OA of the knee and CVI among the Indian patients was considered in a clinical based real life setting. Objective was to evaluate the prevalence of knee or ankle arthrosis or arthritis among Indian patients with CVI presenting with healed, that C5 or active C6, in a prospective clinic-based study. And we had these patients because actually we have also treated patients in the class 3 and class 4 category of venous insufficiency, but C5 and C6 are the patients who would seek the attention of the phlebologist. Next, please. So the study center was Silverline Hospital in Ernakulam, India. These were where the patients were actively recruited. Study period was from between April 2019 to March 2020. The study data is from the Indian National Venous Ulcer Registry of India under the aegis of the Venous Association of India. Patients presenting with C5-6 venous disease with suspected or diagnosed OA were included in the study, and the study had and still has institutional review board approval. Please, next slide, please. So based on the protocol and defined eligibility criteria, patients with deep vein thrombosis or the post-phlebatic syndrome and rheumatoid arthritis were excluded. Now, the investigations that we did was a color Doppler, of course, for venous study of the lower limbs, vitamin D3 levels, and we published this in a previous publication it's in a Hungarian journal. Vitamin B12 levels, X-rays, that's knees, ankles, or both. Knee X-ray examined for osteophytes, loss of articular space, and loss of articular surface alignment compared with the opposite side was also done. Ankle X-rays were examined for talocalcaneal and mid-tarsal, subtarsal joint space defects. and were reported by a radiologist. MRI was done for a few patients, and clinical examination included a general examination, medical history, symptoms, signs, and severity. And additionally, we did the knee and ankles for range of movement or motion limitation, loss of arch of foot and claw toes, and anteroposterior and lateral weight-bearing X-rays. And going back to the vitamin D3 levels, we have, I think Dr. Roy Burgess in his previous presentation did mention this, and we have made this as a presentation at the American College of Phlebology also, I think in 2017. So there's an association here. Next, please. So this is the breakdown of the demography of our patients, the gender, which is very surprising that all patients were females. And we don't know why, but I think this is females are the ones who get the least attention, or females are in the family seek attention at an advanced stage, or that females always have covered legs, and probably these changes go undetected or unnoticed by the other members of the family. And the age in years 57 plus minus 10.5, and so on and so forth. The weights average, and the BMI, of course, is slightly more than average. And the comorbidities, again listed as for diabetes, hypertension, osteoarthrosis. You'll see that they were every patient had osteoarthrosis, rheumatoid arthritis, eight patients, hypothyroidism, hyperthyroidism, celiac disease, metabolic disease. So that's the breakup of the additional problems that the patients had, but osteoarthrosis was the presenting problem that we were looking at and trying to associate it with an underlying venous insufficiency. Next, please. So these are the symptoms, number of patients, 175. How we reported was this was a visual scale, mild, moderate, difficulty in walking, heavy legs, swollen ankles, restless legs, pins and needles, discolored and bulging veins, uncomfortable legs, and tingling. And the numbers are there. And later on, I will share the link on which you can find this publication in a peer-reviewed journal. So that would be for all of you to take a deeper look or take a deep dive into this, the data. Next, please. So knee X-ray and assessments, again, within normal limits, the early osteoarthrosis or severe osteoarthrosis, again, a breakup of the number of patients reported by a radiologist and the range of motion of the knee, again, the values in the standard measurements. So that's how we broke up the patients with the knee X-ray and assessments. Next slide, please. This is some of the dramatic X-rays that we had and pictures that we shared with everybody in the publication. Of course, you will see the osteophyte production, the joints of the feet, and so on and so forth. Next slide, please. Again, the planes and the loss of the arch of the foot, how these people look on the X-ray. Next slide, please. A close-up of all the flare-up of the issues that are occurring around the joints of the foot, the subtalar, and the main ankle joint, as you'd all see, and again, a flat foot. Next, please. A view from the top. Next, please. Again, standard weight bearing, osteoarthrosis, loss of the articular space. Next, please. One more in standing. Next, please. So what was the treatment protocol? Obliterative definitive treatment of the superficial venous reflux by thermal endoablation of the saphenous trunk. We belong to the school of thought in which we still do obliterative treatment. We don't have the, or we are not yet in this sort of patients trying to do some conservative therapy like the Shiva or the other sorts of, saphenous trunk sparing surgeries. We go for an obliteration. Then there is ultrasound guided foam chemical endoablation or sclerotherapy, or foam sclerotherapy, it's popularly known as, for the tributaries. And below knee compression stockings, 25 to 30 millimeters, are always prescribed for the patient. Supportive footwear with correcting insoles. So number of patients with compression, 195, thermal 195, chemical everybody, footwear 193, insole 194, and again vitamin D3 deficiency in 188 patients. Everybody got micronized purified flavonoids, 197 of the patients, pain relieving medications of course, and dosulepine, that's a little antidepressant which we try to give so that their depression or their chronic situation does not make them unhappy about a slow outcome. Patient follow-up at 3 and 6 months from the treatment initiation, and the treatment with micronized purified flavonoids and vitamin supplementation was continued all through the 6 months, and no hypervitaminosis was observed in any of the patients. Personally, we have started to believe that hypervitaminosis D is very, very difficult to produce and we were actually also surprised that all our patients had vitamin D deficiency, and it is endemic in India. Even though we live in a sunny country, I tell my patients that even though we live in a sunny country, it's not that we go out in the sun, we just see the sun from inside the four walls or from our windows or from our air-conditioned cars or whatever it is. Next slide, please. So treatment assessment was done by the investigators, 186 patients. Now this is huge. 94.4% had a good improvement and 8 patients had fair improvement. Obviously, this is over a period of 3 to 6 months. This happens gradually as the body now starts to regenerate. And the reason why it is able to regenerate is physiological, and I will explain that to you. In fact, we have given a detailed explanation in our publication. And the visual assessment score by the patients, you would again see that baseline and post-treatment, how well these patients respond. You would like to see them at the end of 6 months, you would be really surprised. Next slide, please. So results and conclusions, and I have broken this down into 2. And OA observed was the result of long-standing, undiagnosed and untreated chronic venous insufficiency. We are making this strong statement, even though it's based upon a correlational study and it's a single center, but we make this strong positive statement. The cases were referred for the treatment of venous ulcers, and this is where we got our referrals, because once these patients have a venous ulcer or an ulcer that is recalcitrant or goes into a chronic stage, then people start thinking on the lines, other physicians, other medical practitioners start thinking on the lines that, oh, there could be some venous disease. And then they spot a little dilated reticular vein or a little varicosity or a little bulge here or there on the leg, and then they send it to the phlebologist. The Doppler evaluation helped diagnose the Phleboarthrosis of the knee that progressed to osteoarthrosis due to long-term venous stasis. We are able to see the knee joint effusions and the effusions in the ankle joints. All the 197 patients of women, reconfirming high prevalence of CBI among women globally. And of course, in India, we have a special or very unique socio-economic conditions in which women usually are referred or get referred late during their course of their suffering. The patients had low vitamin D levels, further suggesting the low nutritional levels among the cross section of the society, especially amongst the female gender. The long-standing chronic venous insufficiency among these patients was associated with low vitamin D levels and general poor nutrition, lack of physical exercise, and comorbidities. And I would also try to refer here again to one of the presentation made in 2017 to the American College of Phleboarthrosis. It was again based upon a series of patients in which when you correct vitamin D level, your requirement of pain relieving substances go down. So we have found that vitamin D in these cases gradually restores the internal milieu, and the patients are able to regenerate their bones or articular surfaces in a better way. The long-standing chronic venous insufficiency among these patients was associated with low vitamin D levels and general poor nutrition, lack of physical exercises, and comorbidities. Jointly, it progressively impacted the bone architecture, leading to osteoarthrosis of moderate to severe intensity, affecting day-to-day activities and poor quality of life. I think this would make some sense. Now, as you look at the logic, you would understand why we combined these simple modalities with each other. Next slide, please. In all cases, the superficial venous reflux compounded the pathology around the knee. Vitamin D3 supplementation or micropurified flavonoids, 1000 milligrams were beneficial. Compression therapy of the legs helped to increase pressure on the skin and underlying structures to counteract the force of gravity, to reduce swelling and aid in ulcer healing and improve mobility. Dosulapine helped relieve the pain and improved mood among the patients. It improved their emotional health and compliance to therapy. Now, let me get back to point number one. Why is superficial venous reflux? Why does it compound the pathology around the knee? When you have superficial venous reflux, please never ever think in isolation that the venous insufficiency is affecting the subcutaneous tissue. It is affecting the venous return of the bones also. There are bony perforators. Almost every radiologist or pathologist has seen the bony perforators. These bony perforators also have a reflux. The internal milieu of the bones undergo or stay in a relative state of congestion. Now go back to your anatomy and you would realize that the knee joint is a structure that is held together by almost non-vascular structures. The cartilage that is on the articular surface does not have a blood supply of its own. The aponeurosis, the ligaments around the knee joint, do not have a very direct blood supply. Most of it relies upon diffusion, and you can understand that the slightest increase on the venous side, the pressure or the backward pressure would start slowing down the diffusion.
Sir, I think you're not audible, sir. Hello? Still not audible, sir. So is it possible to connect your Bluetooth again? So your system is on mute right now.
Okay,
Yeah.
can you hear me now?
Yes,
Okay,
sir.
sorry about that interruption. I don't
No
know.
problem.
Technology sometimes does that. So
Sure, sir.
basically, when the bones are in a state of congestion, the regenerative power or the healing is slowed down, and obviously the wear and tear cannot be repaired in time, and then you have another episode of wear and tear as soon as the patient starts ambulating the next day. So can I have the next slide, please? So key learnings. As soon as the venous flow was corrected, patients improved. Knee joint stability and integrity relies upon soft tissues. All soft tissues get nutrition by diffusion. When there is venous insufficiency, there is congestion. This causes malnourishment of tissues, leading to delayed healing of normal wear and tear. The affected area starts to fall in limited use, and finally fixed deformities develop. The foot arch starts to collapse, with further affection of muscle tissue integrity as the muscles get over or underused. And then special muscle groups are targeted by the during the ambulation, and some get underused, some get overused. Any patient developing evening lower leg or ankle edema should be investigated early for venous insufficiency along with orthopedic referral. And let me emphasize, chronic venous insufficiency, especially from the superficial venous system, will not be visible as varicose veins in many of our Indian patients. We have a lot of subcutaneous fat, and the varicose veins are hidden underneath the skin inside the subcutaneous fat. So when the venous insufficiency is corrected, the knee joint can be preserved. Or if the knee joint has been replaced, it will settle down much better or faster. Next slide, please. Venous stasis and venous outlet syndromes are the key circulatory pathologies associated with the initiation and progression of osteoarthrosis and is known and reported. Somehow the English literature forgot about this. The French and the German literature know about this, and for them Phleboarthrosis, even the Romanian literature, Phleboarthrosis, oh yeah, we know, we do it all the time. That's what they say. So our study confirms the underlying pathophysiology of OA associated with venous stasis among our patients. Clinical diagnosis of Phleboarthrosis is essential. And that, again, as we have been taught right from our clinical days, that a high index of suspicion. Pain and swelling in and around the knee joint at rest and on movement with involvement of soft tissue and cartilage injury must be investigated for venous reflux. Treating superficial venous reflux can yield better recovery from future surgeries around the knee and ankle or foot joints. Next, please. These are the links to the publication. This was published online on September 18th, 2021 in the Indian Journal of Surgery. We targeted the Indian Journal of Surgery as our first choice, and we are very thankful to the senior editors, the chief editors, and the other editors who went through our paper to publish it because they realized the importance of this. We published it in a Journal of Surgery because we wanted it to go to a very, very large audience. And so there is one link which is actually will take you to the abstract. The second link will take you to the and allow you to download the PDF of the article. And this is the whoever gets the physical form of the journal. This is the Indian Journal of Surgery, and the link in there. This is in September, and it was published online September 18th once again. Next, please. And this is the extensive bibliography that we have taught. And at the end, you will see that how wound care practices for infected venous leg ulcers and prudent use of vascular disease. This was abstract published in Hungarian Journal of Vascular Disease. Like I said, sometimes we make a presentation and then it gets published in a place which is not commonly or widely read. But as you can see here, This is in 1972 that this was reported here, and in the German literature again. And as we go and then you find that there's a reference to 1965. Can you believe that? And then people forgot about this, and it was actually described at that time, but then we had to wait for the ubiquitous or very widespread use of the Doppler or the color Doppler or the ultrasound or the duplex scan to come to this stage of understanding. Next, please. So thank you. Phleboarthrosis of the lower extremities due to chronic venous insufficiency and underrated condition is what I gave you. I talked about today. Again, the presenting and conceptualizing author, the data collecting author, and the data analyzing author listed again. I would be most happy to take any questions, and I want this to be understood by those who are here today that please look into this in your patients. Thank you very much for listening to me. Thank you again, Dr. Plexus, Dr. Bedi, the leaders of the Venous Association of India, to give us or give me this opportunity to make this presentation. Thank you again. Thank you very much.
Thank you so much, sir. And since we know that this topic is not very widely researched or spoken about, it was an absolute pleasure to know about such a common yet underdiagnosed condition. We do have certain questions for you, so we'll take them one by one.
Yeah, I'll be happy to answer them. Yeah, please shoot.
So my first question is from Dr. Deba Singh, who says,
yes.
How are phleboarthrosis and osteoarthritis of the knee joint related?
We have joined the two terms as like the arthrosis of the lower extremity related to a phlebological condition. So that is why there's the phleboarthrosis. It's basically I would say, a Latin word, because this was first described very extensively in the German, French, East European literature. So I am, it's like the joining of two words, as arthrosis related to a phlebological condition.
Sure, sir. So what are the warning signs of phlebitis? I think, yeah.
So the warning signs, of course, of phlebitis is a sort of a term that is used in a general sense. I would say that if you have any indication of observing even spider veins or reticular veins, which are dilated veins less than 2 millimeters in diameter, but even if you see telangiectasis or you see spider veins on the legs or thighs of a patient and no varicosities are seen, but the patient has pain around the knee joint or around the ankle, please get a color ultrasound or a color duplex done for the superficial venous system, and you will be surprised. You will not regret your investigation.
Sure, sir. So my next two questions are from Dr. Mangesh Tarte. So his first question is phlebological talipes equinus, which is joint deformity, associated with C6 active venous ulcer, is phleboarthropathy or some other joint deformity?
Hard to say for me right now, but I think treat the venous insufficiency first and then go after the joints, because treat the venous insufficiency first, because that's the most obvious from this correlational study. And why not correct the milieu interior? Why it makes sense that it's logical to take care of the venous congestion, and then you can have the orthopedic treatment or the musculoskeletal person working on it have better outcomes, have much better outcomes than what he would do if they had not treated the venous insufficiency.
Sure, sir. His second question is, what are the endovenous treatment protocols in Klippel-Trenaunay syndrome, which is KTS cases, associated with congenital varicosities, having hemarthropy, knee joint deformity, limb shorting, etc.?
I would like to leave the answer to this question when I'm sure that in the series planned, there is a special feature, special evening dedicated to treatment of Klippel-Trenaunay syndromes and or congenital. And if it's not there, this is a good point that he has brought out, that we should have a special session on the treatment of these sorts of congenital anomalies giving rise to the complications and how to treat them. So I think let us have another topic based on this, and if the leaders can make note of this, and that would be the best time for this question to be answered.
Sure, sir. No problem. Now moving on to other questions. One of the questions is from Dr. Kotwal, who says, what happens to varicose veins during flights?
I think the varicose veins, the blood flow inside them, of course, stagnates a bit more. The pressure in the cabin decreases, is less than the atmospheric pressure that we usually have. So based upon my high school physics, I would say that these stagnated blood, the veins dilate a bit more. There is more stagnation, so there is a higher chance of superficial vein thrombosis developing. That's the only thing I can comment right now on this.
Okay. So now, sir, on the research that you presented, so during duplex ultrasound assessment as well as CT venography, venous perforators of knee are often ignored due to their small caliber. So what are the ways to visualize these venous perforators better?
No, I think first of all, examining the patient in the standing position, and the duplex ultrasound is still the gold standard. The CT venography may not give you a idea of the perforator reflux, because it's not, even though it's taken real time, it is not dynamic. While the duplex ultrasound is a dynamic study, you are actually seeing real time what the reflux is, if there is a reflux outward, or there is actually a vein that this perforator may actually be relieving the congestion and be acting as a drainage point for some vein above. So if you are faced with such a dilemma, then the phlebologist or the vascular surgeon or the general surgeon should personally go to the radiologist clinic and observe it again. That's my best suggestion.
Sure, sir. Now we also have a lot of orthopedicians watching us here. So what point should an orthopedic doctor consider before concluding that the osteoarthritis is likely due to venous insufficiency and refer this patient to a doctor specialized in venous insufficiency?
Okay. I've been waiting for a question from our orthopedic colleagues, because this is where what happens is that this is where the synergy between the orthopedic surgeon and the phlebologist or the vascular surgeon or the general surgeon comes into play for better outcomes and less happy patients. I think the orthopedic surgeon should look for on the legs is edema. That's the first thing. The second thing is pain around the knee joints. Of course, that the orthopedic surgeon is always going to look for, because that's what the patient came to them in the first place. So edema of the legs, number one. Number two is if they even see the smallest reticular vein or a spider vein on the legs, they must go for a color Doppler evaluation, or hyperpigmentation of the skin over the lower leg, even spots, a area, a rash, or a generalized hyperpigmentation, a small area, or some hyperpigmentation that is scattered. Please do not ignore that. Let the patient have a color Doppler. It's least invasive in that sense, or I would say non-invasive, easy to do, and will give you accurate information. Make sure that this patient is examined in a standing position, never in a supine position.
Sure, so I think that would help. This brings me to my last question. So, which is, would you prefer managing an affected patient solely for venous insufficiency or an adjuvant to osteoarthritis management?
I would, my general, the practice that I follow is that if I see a patient who has venous insufficiency and has pain around the knee joint or around the ankle and the foot, I involve the orthopedic surgeon and tell him that I'm going to treat the venous insufficiency. You treat the musculoskeletal or the residual musculoskeletal problem. I also now, with this awareness, get referral by the orthopedic surgeons who tell their patients that get the venous insufficiency treated, and I will simultaneously treat your joint pains. And most of the times we have seen that we have been able to preserve these knee joints for several years now. It's been, we've had this experience. But the thing was that simple experience is not enough. And that's why this publication.
Sure, sir. I think so. These were all the questions that we had. So,
can I make a last point?
Yes, sir, please, sir.
There may be an unanswered question or a question that may crop up later as to why we just followed our patients for 6 months. I think we did very well in trying to follow them up for 6 months. In India, anything beyond 6 months, please. It's very hard to trace these patients. So that's the only reason. So I would put this as a limitation, or I would put this as a social limitation to the study, that going beyond 6 months in India is almost, we had, Roy, our Dr. Varghese had to literally push his staff to contact these patients on the phone, or write letters to them, or do whatever, please come, we want to evaluate you. So it becomes very difficult. So that's one of the questions that may pop up later, and I'm sure everyone who's from India on this presentation right now understands our peculiar situation. Thank you.
Sure, sir. So, any closing remarks for our audience who's watching us here?
Please, let's help our patients overcome 2 conditions at the same time, and not let them, and keep their natural knee joints forever, or till they get cremated or get buried, or whatever their situation is. And let us not give them a prosthesis, or try and delay them getting a prosthesis. And if they have to have a prosthesis, that's fine, but let that prosthesis also work in the best possible manner. That's my message to all.
Thank you so much, Dr. Patel, for such a well-presented case. And it was lovely having you with us here.
Yeah,
I would also like to... Yes, sir?
It's been even more pleasurable for me to make this point. And once again, thanks again. I cannot thank our leaders and Doc Plexus, less or more, or I would just keep on doing that. Thank you.
Sure, sir. Thank you so much. I would also like to thank our audience for attending the session and making it more interactive with your questions.
Now, the audience is most important for us, and yes, especially the orthopedic surgeons, the general surgeons, everybody who's watching this, even the dermatologists, whatever specialty you are, general practitioner, anybody, you would now have a rethink when you see these patients.
True. I'll also, please feel free to send us any more questions if you have, and we will make sure that we get back to you on them. And stay tuned for our next VAI Master Series with Dr. Deepak Selvaraj, who is going to talk about venous ulcers next Friday, 3rd December on 6 p.m. onwards. So until we see you again, please take care and have a great evening ahead. Thank you so much, sir.
Thank you. Take care, and be careful of the new COVID variant.
Correct.
use your mask.